Florida, Mr. Bilirakis for 5 minutes.
Thank you, Mr. Chairman. I want to thank you again and the ranking member for holding this critical hearing on medical innovation and the need to ensure that Medicare beneficiaries have access to treatments and cures being developed for patients in need, particularly those who have debilitating, life-threatening diseases that no alternatives exist. And while drugs have historically had a pathway forward, devices too often get lost in bureaucracy. That's why I'm proud to help lead the Ensuring Patient Access to Critical Breakthroughs Products Act, H.R. 1691, with my bipartisan colleagues, again, Representative Cardenas, Winstrup, Delbeni, and of course, our chair, Mr. Guthrie, and our ranking member, Ms. Ashew. Our bill will provide a statutory pathway for Medicare coverage for medical devices approved by the FDA under the Breakthrough Devices Program. We want to expand upon and strengthen the policies recently laid out by CMS in their proposed transitional coverage for emergency technologies, TSET guidance, recently released. But I would be remiss if I didn't express disappointment that TSET doesn't go further and only expands Medicare access to only a small number of innovative devices under the existing national coverage determination pathway compared to the now repealed MCIT rule. So my questions are, let's see, Dr. Miller first. I understand that there are vastly different levels of expertise and staffing resources between FDA Device Review Group and the Medicare Coverage Group at CMS, which has a much smaller footprint of medical experts on staff. Can you elaborate on the respective roles of the FDA and CMS and whether CMS should develop a means to harness external expertise without overstepping its statutory role, such as unnecessarily requiring duplicative studies redundant to what the FDA has already required? If you could answer that, I'd appreciate it, sir.
Thank you. So the FDA ensures that products are safe and effective. The CMS ensures that they're reasonable and necessary for the Medicare population. So the FDA device might, or the FDA approved or cleared device may or may not be tested in a population that's exactly representative of the Medicare population. So that's one issue where the FDA and CMS working together could improve that. We have the parallel review program, which is a good effort, but unfortunately operationally hasn't really changed that. I think that the problem is as I said, CMS has a variety of tools and it doesn't use them. It has the Medicare Evidence Coverage or Evidence Development Coverage Advisory Committee, which is 100 members. They haven't had many. They had, I think, 14 meetings of that over the past 10 years, even though the charter says 2 to 4. And when it was first set up in 2000, they had 6 meetings in that first year. So they have the external experts. They've recruited them, screened them. When I joined, and I'm no longer a member, I did, I think, 263 pages of paperwork. So it's not exactly a low entry barrier. You have to undergo ethics screening. So CMS has those tools. They just have chosen not to use them. That's why I think they need to have a statutory requirement for issuing guidance as to when they use which tool, when they're going to do an LCD, when they're going to do an NCD, guidance for when they convene an outside technical assessment, guidance for when they convene the MedCAC, and then timelines for each of those.
Thank you. Along similar lines in the policies being put in place by CMS with TSET, there are also bipartisan concerns surrounding the NCD for beta amyloid reduction treatments for Alzheimer's disease. Ms. Wronski, you mentioned in your testimony that the coverage with evidence development, CED determination, that CMS has decided for a fully FDA-approved drug has never been put in place before. Can you speak to the need for CMS to reconsider putting up these barriers and replace it with the NCD that makes patient access as easy as possible when it's medically necessary? I, too, have a a loved one with mid stages of Alzheimer's. And of course, I have a lot of constituents that unfortunately were diagnosed with Alzheimer's. If you could answer, I appreciate it.
Thank you, Congressman, for the question, and we appreciate your support on the issues as well. I think I just need you to repeat the question one more time.
I'm sorry.
No, that's okay.
Okay.
Well, we're time's
Can you
past
speak to
time.
the need for?
Hey, Mr. Miller, we're about to have 30 seconds over time. Can we pick it up?
All right,
another-
I'll actually.
Thank you,
submit it for the
Congressman.
record. I appreciate it very much. I yield back.
Thank you. The gentleman